In this lecture, we're going to talk about pain. I've mentioned previously that pain is a very complex phenomenon, and I'm hoping that after hearing some of the information that I'm going to give you, that you begin to realize just how complex pain really is. Take a look at this picture and see if you can figure out what is wrong with this particular picture. And then look at the caption, and you'll agree that that's gotta hurt. The International Association for the Study of Pain, or the IASP, is the international body that is considered the authority on pain. The definition of pain, according to the IASP, is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. Looking at this definition, I want you to pull out a few key things. First of all, that pain is not just sensation. Pain has other components to it, including emotional, and pain is always unpleasant. It is not necessarily associated with tissue damage. There could be only potential tissue damage, or there may be no risk of tissue damage, but the individual experiencing the pain describes it as if there was tissue damage. Nociception is the generation and transmission of action potentials from a nociceptor through the nociceptive pathways in the central nervous system. However, nociception is not pain. We can have pain without activating nociceptors. Pain is a multidimensional phenomenon. It may include nociception, although it does not have to. But it does include emotion and cognition. In order to try and grasp the full phenomenon of pain and its impact on an individual, we really need to use multidimensional assessment tools. A typical numerical rating scale, how bad is your pain, on a 0 to 10 scale, is unidimensional. It gives us one piece, one aspect of pain, and it really misses out on the complexity of this phenomenon. Pain can be experienced without tissue damage. A good example would be individuals with fibromyalgia. We are unable to find any type of tissue damage associated with fibromyalgia. Yet these individuals experience real pain, and they experience pain in multiple parts of their body. Pain has various dimensions to it. It has a sensory discriminative component, a motivational affective component, and a cognitive evaluative component. The sensory discriminative component gives us an idea of the location of the pain, the timing of it. Is it constant? Is it intermittent? How long is there between episodes of pain? What's the quality like? Is it sharp? Is it burning? Is it stabbing? And also the intensity of that pain. Think what, where, and how much. Motivational affective component of the pain involves the effects of pain on experience and behavior, and vice versa. It is the unpleasantness of the pain. And then cognitive evaluative is the meaning that is attributed to the pain by the individual experiencing it. Does having this pain mean that you are going to die? Or does having this pain, do you recognize that this is not harmful, it's not going to hurt you, it's something simple that will heal and everything's going to be okay. How you think about the pain really impacts your overall perception of that pain. Factors that contribute to the pain experience include biological factors such as a disease process, your physical condition, any medications you might be taking, psychological, such as behaviors that you exhibit when in pain, how you cope with the pain, your sense of self-efficacy, which is your ability to control the pain, how helpless do you feel to do anything to modify the pain, your thoughts regarding the pain, and your overall personality. And social factors. Do you have social support, or are you isolated and on your own? Are you married, and what is the status of your marriage? How does your family respond to you when you have this pain? What about cultural practices and beliefs? Are you supposed to be stoic and buck up, or is it okay to show that you are hurting? We've talked about the primary and secondary pain pathways. And as I've mentioned, I really don't like those terms. One is not more or less important than the other. They provide different aspects to the pain experience. The primary pain pathways are really, as I said, I think would be better described as more of our discriminative pain pathways, because they're giving us that idea of where does it hurt. This would be our spinal thalamic tract. And we haven't talked about the trigeminal thalamic tract yet, but that's the tract that's going to be bringing pain from our face to our brain. And then we've mentioned the other pain pathways involved with arousal and attention to the pain, the autonomic nervous system response to the pain, and activating different systems that are endogenous or inherent within us that can modulate the pain. There are several brainstem and forebrain structures that are involved with the experience of pain. And together these structures are known as the pain matrix. This is just an image to help give you an idea of the multiple places within the brain that are involved with the experience of pain. This doesn't even include the brain stem or the spinal cord. We're just focusing on the cerebrum here. All of these different colored areas are areas of the brain that are part of the pain matrix. The color coding helps to distinguish if they're involved with the sensory discriminative aspect of pain, the affective aspect of pain, or the cognitive evaluative aspect of pain. These brain structures that are involved in the pain matrix are all structures that help to process and regulate pain information. The structures of the pain matrix are capable of creating a perception of pain even in the absence of nociception. Whether nociception is present or not, these same structures are also able to increase or to decrease the perception of pain that you experience. There are several definitions related to pain that I want you to know. You will see these in the literature, and you should know them for documentation purposes and if you see them in a patient's chart. Allodynia is a painful response to an innocuous stimulus. Something that normally doesn't hurt is experienced as painful. For instance, a light touch on your skin shouldn't hurt. But if you have sunburn and you lightly touch your skin in the area of the burn, it hurts. That's allodynia. Touch is normally an innocuous stimulus, but it's now felt as painful. Allodynia can occur even without an obvious physical injury. As I have said, pain can be felt even in the absence of nociception. So any kind of stimulus that would normally be expected to be non-painful, but is experienced as painful, is known as allodynia. Analgesia is the absence of pain in response to a stimulus that should normally be painful. So if I stab you with a needle, that should hurt. If it doesn't, that would be analgesia. Dysesthesia is an abnormal, unpleasant sensation. It can occur either spontaneously, just out of the blue, or it might be provoked by a particular stimulus such as a breeze, a cold breeze blowing against your skin. Dysesthesias are often described as like bugs crawling or other unpleasant sensations. Hyperalgesia is an increased perception of pain in response to a noxious stimulus. So you have something that you would expect to hurt, but it hurts more than it normally would. That would be hyperalgesia. Pronociception is due to sensitization of the pain system. This is an amplification of pain signals. Antinociception is really the opposite. This is an inhibition of pain signals. Higher centers within our nervous system, so centers located in the brainstem and the cerebrum, are capable of either pronociception or antinociception. Anesthesia is the absence of all sensation, including pain. So analgesia is specific to pain. Anesthesia means all sensation. There appear to be differences between men and women in how they experience pain. This is not 100% certain. There are several studies that conflict with each other, but overall, when looking at meta-analyses that take all of the different studies that have looked at sex differences across the board, it does appear that women may experience greater pain with the same noxious stimulus than men. Women may have lower pain thresholds than men, so they will feel pain sooner. So I apply a stimulus, women are more likely to feel pain from that stimulus earlier than men will. And women tend to rate the pain as being higher intensity than men with the same stimulus. These differences may persist with aging. In my studies, I examined aging and pain perception. I had some mixed results. In some studies, I saw that women indeed had lower pain thresholds and higher pain ratings in both younger and in older adults. In other studies, I did not see these same findings. It may be that the findings are more subtle, and so we need a large number of people in order for them to be consistently found. So it's still a little bit unclear, but it does appear that there are sex differences, and these sex differences may persist as we get older. The mechanisms for the differences between the sexes is unclear. The most obvious one is looking at hormonal differences, but those hormonal differences are reduced once we get postmenopausal, and yet there's some indication that the sex differences persist in older adults. Additionally, when studies have objectively controlled for phases of the menstrual cycle, for instance, they have failed to find the differences. So hormonal differences may not be the answer, or may only be one piece of the puzzle. Now I want to talk about acute pain. Acute pain is pain that is associated with actual or potential tissue damage or occurs in response to tissue injury. By potential tissue damage, think about if you have a rock in your shoe. When you step on it, it hurts. It hasn't yet caused any damage to your tissues, but there's the potential there. You remove the rock and the pain goes away. No damage incurred. If you fail to remove the rock, that rock may eventually break down the skin and cause you to have an injury. So acute pain, there may be actual tissue injury, or there may be the potential for injury without tissue damage actually occurring. Acute pain is protective. It helps you to prevent developing tissue damage or to further the damage that has already occurred. You do healing behaviors such as limping, so that you decrease the weight bearing on the affected limb. You hold the limb protectively next to you because movement is likely to cause further damage, etc. However, there is a very important concept that many people do not understand, and that is that the amount of tissue damage does not equate to the level of pain. You can have an extensive amount of tissue damage and have very little pain. On the other hand, you can have a small amount of tissue damage and have a large amount of pain. For example, a paper cut oftentimes is quite intense, but yet the amount of tissue damage is minimal. We see this with patients as well. Some people will think that someone is overreacting. Their injury was not that severe. There's not, a lot of damage. Why are they acting like such a baby? And why are they whining so much? Well, that particular person is experiencing more pain than you might expect to experience. But that does not mean their pain is not real and that the intensity of the pain they're experiencing is not real for them. There is not a positive correlation between the amount of tissue damage and the level of pain experienced by the individual. The affective and cognitive components of pain really have a significant impact on the total pain experience. You look at that paper cut, it's really hurting, and you say, it's just a paper cut. It's going to be fine. The pain level starts to come down. How you think about pain and how you feel about the pain and what it might mean and what its impact is, all can dramatically affect the total pain experience. This is a great case in point. Those of you who are basketball fans may remember when Kevin Ware, who was in the Sweet 16, was injured. This was in the spring of 2014 or 2013. I think it was 2013 season. Here are some quotes from Kevin on the injury that he experienced. And for those of you who may not be familiar with this injury, Kevin Ware came down with he had kind of twisted a little bit in his leg as he came down with the basketball. And he ended up shattering his tibia. His tibia fractured and came actually forward out through his skin. So he had a compound fracture of the tibia. So it was protruding out his anterior shin. So he's laying here on the court. His bone is protruding out of his leg. And here's what he had to say. He got me to that point where I really had to put the pain on hold. Once he said his prayer, I was kind of thinking the whole time, you can either be a crybaby about it, or you're going to get your team back and get them into the right mindset. Luke said his words, and I just kept repeating, y'all got to go win this game. I'm fine. It really helped the team. It was one of those things where I couldn't believe it. I honestly didn't feel the pain. It was more a shock. So this young man is laying on the court. His tibia is protruding out of his leg. His teammate got down on his knees and said a prayer with him. And following the prayer, he was so concerned about his team getting back into the game and winning that game that he didn't feel the pain of that injury, despite the intensity of the damage. Uncontrolled acute pain has been shown to increase the risk of developing chronic pain. Therefore, it's critical that as healthcare practitioners who are working with people with pain, that we manage that acute pain well. It's really important to manage acute pain to help minimize the risk of the development of chronic pain. Here are some of the characteristics of acute pain based upon the location of the tissue damage or potential damage. Cutaneous injury tends to lead to a localized, sharp type of pain. Muscle injury leads to more of a diffuse, dull, aching, and cramping type of pain that frequently refers to elsewhere in the body. Neuropathic pain, which means pain due to injury to a nerve, is felt as burning and shooting and often produces tingling sensations. And visceral pain is often felt as diffuse, dull, stabbing, or cramping. Visceral pain also frequently refers, and many times to areas very unrelated to the origin of the pain. Chronic and persistent pain are similar. The main difference between chronic and persistent pain is that with chronic pain, you are having pain that has outlasted the expected healing time for the tissue. There is no underlying pathology to explain that pain. Pain is no longer protective. With prolonged or persistent pain, there remains an underlying pathology. Arthritis is an excellent example. You still have inflammation of the joint tissues. You have thickening of the synovium. You have osteophytes that are creating pressure onto the soft tissue. So there is an underlying pathology that is persistent for a period of time. We can kind of think of this as a prolonged episode of acute pain. Another way of thinking about prolonged or persistent pain is if you have a relapsing, remitting pathology, such as migraines. They come, they may be gone for a day or two, then they come back again, and then gone, and then come back again. So this relapsing of pain would fit more under the prolonged or persistent pain as opposed to chronic pain. But you will find that people oftentimes use the chronic pain term indiscriminately, meaning any of these kinds of pain. Chronic pain becomes maladaptive, and with both chronic and persistent pain, we see sensitization of the pain system. It's interesting to note that chronic or persistent pain affects more American adults than those that are affected by heart disease, cancer, and diabetes combined. And finally, I want to discuss referred pain. Referred pain is perceived as coming from a site different than the actual site of injury. When I mentioned about visceral pain, often referring to sites totally unrelated, the most common one that we think about is heart, with pain emanating from the heart being felt down the left upper extremity. Now, one thing I want to mention is that's true for men. It's not as true for women. Women, in many cases, who are having a heart attack do not have the left arm pain. That's much more common for men. Another common one is gallbladder. Someone who's having pain originating from spasms of the gallbladder will often complain of pain up by the scapula. So if someone's coming to you because they're having scapular pain and you're thinking this is an extremity problem, and you start asking them about the history of the pain, and they describe a worsening of pain every time they eat, particularly if they eat a fatty meal, I would be suspicious of a possible referred pain from the gallbladder. especially if your musculoskeletal assessment did not have any findings that seemed consistent with pain in that region. We don't really understand referred pain. Some people think that it is because neurons from the viscera converge on the same second-order neurons in the spinal cord as those coming from the muscles or the skin, and so the brain gets confused as to where the pain is coming from. But if that were the case, we should see that when you have skin injury, it should refer to these other areas like the viscera, but that does not happen. It's only viscera referring elsewhere. Those other areas don't refer to the viscera. So we don't really understand the full mechanisms behind referred pain. I'm going to stop at this point, have you take a break. Again, I want to keep encouraging you to take frequent breaks and be active during those breaks. And then you can go ahead and start looking at part 2 of our lecture on pain.